So welcome everyone. Thank you for coming. I'd like to welcome you to the June session of the Erie County Workforce Collaborative Training Series. The Erie County Department of Mental Health is thrilled to be able to offer these trainings to the dedicated providers in our community. These trainings are being offered to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we are so fortunate to have Dr. Celia Spacone, coordinator of the Erie County Suicide Prevention Coalition, and Katie Coric, the Suicide Prevention Coordinator from the VA Western New York Healthcare System, to share their expertise in their presentation entitled Lethal Means Reduction, the How of Suicide Prevention That Makes a Difference. I'm pleased to announce the topic for July will be co-occurring disorders, and our presenter will be Jillian Warner Dombrowski. She is the co-occurring disorders supervising counselor at Transitional Services, Inc. She will be sharing her expertise on co-occurring mental health and substance use disorders. That's scheduled for July 27th. You can go to the Erie County Department of Mental Health website to register, and I will be posting the link to the registration at the end of this session. In August, the topic will be focused on kids and families and the transition back to school with presenters from Child and Family Services. More information will be coming on that. As many of you may know, our colleague, Dr. Kirsten Vincent, passed away on May 31st. She was our presenter for the April and May sessions about vicarious trauma. Kirsten was the CEO of Recovery Options Made Easy, was a leader in our systems of care, was a passionate advocate, and just a wonderful, kind, smart woman who will be sorely missed. Those sessions were recorded and are available on our website. Past presentations are also posted there. I did want to mention about Kirsten, though. That's a huge loss for our community. So this is truly a community collaborative, and we are looking for volunteers to fill out the calendar for the year to share expertise with our community of providers. If you are interested in doing a 1-hour presentation, please contact me. Also, if you have a topic you'd like us to cover, let me know that too, and we'll find a presenter, or try to. My email address is amy.rockwood@erie.gov. This training will be recorded. If you're not okay with being recorded, you can disconnect now. Everyone is muted, so if you have questions, please put them in the chat box. Kathleen Larson from the Erie County Department of Mental Health will be monitoring the chat for us during the session. At the end of the session, we will be asking you to complete a very brief evaluation. We hope you'll take a moment to fill this out so we can continue to improve. Thank you all for joining us today, and I'd like to now introduce Dr. Celia Spacone and Katie Coric, who will be sharing their expertise about suicide prevention and lethal means reduction. Thank you so much, Celia and Katie, and it's all yours.
Thank you, Amy, and thank you for hosting this. It's a wonderful opportunity to get some presentations available to the community, and we appreciate all your efforts on this project. Katie, would you like to introduce yourself a little bit in terms of background, and then I'll jump in?
Sure. My name's Katie Coric, and I am a social worker, and I work here at the VA in Buffalo on Bailey Avenue, and I oversee all of the suicide prevention efforts for veterans within Western New York, so even outside of Erie County. I supervise our emergency room social workers who have had quite a year with COVID-19, and I supervise our inpatient psychiatry social workers.
Thank you. And I am Dr. Celia Spacone. I'm a licensed psychologist with a long history of work with people with serious mental illness, most recently at the Buffalo Psychiatric Center, from where I hired 3 years ago as the executive director. And since then, I've been coordinating the Erie County Suicide Prevention Coalition, which has been an honor and very meaningful work. It's open to any agency or stakeholder who is interested in joining, and you'll have my email address provided, so that feel free to send me a note if you'd like to become part of our important work. So today we're going to talk about lethal means reduction. This is just one aspect of suicide prevention, but it's one that we have found has the potential for a large impact. As we begin, though, let me note suicide is a rather intense and it can be a sensitive topic for many people. We know by the rates that many people are touched by suicide during the course of a lifetime. So if you need to take a break or step out, please do so. If you can let one of us know, one of the presenters know that you're doing fine, you just want to take a break. If you do need some follow-up later on, you can contact either myself or Katie. We have our email addresses on this first slide. And of course, immediate resources are always the National Suicide Prevention Lifeline, which the number is on our first slide here, and Crisis Services of Erie County. So feel free to take advantage of those resources if you do need them. This is what we're going to talk about today. We're going to talk a little bit about some of the statistics about suicide in general, suicide here closer to home in Erie County, and then we're going to talk about lethal means statistics and tell you a little bit about why we think this matters. Lethal means refers to the way a person chooses to end their life, as opposed to why they choose to end their life. And recent research has shown that intervening in this area from a public health standpoint can have a great impact, and we'll talk to you a little bit about that. Who should practice lethal means reduction and how to do that, and then we'll give you some resources at the end. So we'll get going with that. Katie's going to begin talking a little bit about some of the data.
Yeah, so we wanted to start a little bit with outlining, at least in a brief way, the scope of the problem, right? So suicide in the United States and actually worldwide is a public health problem. And I've been doing trainings like this for at least a few years, and I don't think I fully grasped what it meant to have a public health approach to a problem until the past few years with COVID-19, right? So I've said things before with suicide prevention, like it's everyone's business, we all have a role to play. And there was something really interesting and sort of eye-opening for me these past few years with COVID-19 is that we truly all had a role to play. And whether that was small or large, whether that was related to prevention or treatment, we all had a role to play. And the same is true for suicide. So the statistics for the United States show that about 45,000 Americans died by suicide in 2017. Including over 6,000 veterans. And, I work at the VA, so a lot of the work I do for suicide prevention is very much veteran focused, but veterans are a higher risk population when it comes to suicide as far as the rates for suicide. So in that same year, which is some of the more recent data we have, the suicide rate for veterans was 1.5 times the rate for non-veteran adults. And then within the veteran population, there's other populations at risk. So our younger veterans, that 18 to 35, have a higher rate of suicide. Our women veterans have, I'll show on a later slide, a higher rate of suicide, pretty significantly higher rate of suicide when you're comparing to women in the general population. Vets in any period of transition, so vets who are leaving the military, or even, transitions clinically, like they're coming out of a rehab program, things like that. I think even as far as like sexual identity and orientation, as far as those transitions are higher risk periods too. Veterans who've had exposure to suicide, really in any way, they've been touched by it with a close loss or within their military service or have had, previous attempts. And then also kind of what we want to talk a little bit about today, veterans that have access to very lethal means for suicide. Okay, so let's bring that a little bit closer to home. We work
very closely with the Erie County Medical Examiner's Office. And I have to tell you, this is a resource that many people don't have. Most communities are waiting for the CDC data to come out and are getting information 2 to 3 years late. So we actually get real-time data from the medical examiner's office, and we've been able to follow the suicide rates in Erie County closely. What I was concerned at the beginning of the pandemic last year when there were people predicting that suicide rates were going to skyrocket. They used kind of inflammatory language, and in those cases, sometimes it can have a self-fulfilling prophecy. But what we found, what seems to be happening nationally, is that the numbers did not skyrocket last year, and in fact, they went down a little bit. Now, in Erie County, we do have the numbers. There's a couple of cases that haven't been closed out yet, but it does look like we had about a 9–10% decrease last year during 2020, which is good news. And we're hoping that maybe that's going to be part of a trend where from the peak that we experienced in 2014 and then 2017, and we're hoping that we're on the start of a downward trend. But it was positive last year. What can happen during a national disaster is that people sort of pull together a little bit more closely. They support each other. And I have to do a shout out for those of you who are working in the mental health field, all the extra work you did last year. And, I think my sense of it could be that the telehealth, which became available, made mental health treatment more available to people. But somehow we pulled together and we did see a small decrease in Erie County.
And I guess I'll piggyback on that too and say that from the VA perspective, we've seen the same thing nationwide as well, that there has not been an increase in the amount of suicides, but anecdotally, we've seen an increase in the amount of people reaching out. So my team monitors local calls to the National Veterans Crisis Line, and we've had about a 20% increase in calls in 2020, and then so far again in 2021. So I think people are still struggling, right, with a lot of changes and, so many cultural factors, pandemic factors, economic factors. And it does appear that people are kind of reaching out for support, and maybe it is easier to access in some ways, via like the virtual modalities. I had mentioned some of these points, but these are just some of the kind of key data points for, veteran suicide statistics. So you can see I alluded to that the rate of suicide for female veterans is 2.2 times higher when you're comparing to, non-veteran adult women. So that's 200% higher, the rate. And then the rate for male veterans is the 1.3% higher. And so then our statistics for veterans look different than statistics for the general population. So if you were to talk to Celia, she would tell you about Erie County. We're doing these projects for men in the middle years because there tends to be a higher rate of suicide when you look at the general population for kind of men in those middle years. For veterans, we see that our 18 to 34-year-old male veterans have the highest rate of suicide, but our 55 and older have the highest count of suicides. So we're actually looking at, the people kind of bookending those men in the middle years. And then when it comes to methods for suicide, 69% of veteran suicide deaths were from a firearm injury. If you were interested in more information on kind of any veteran, suicide statistics or even veteran mental health statistics, the VA does do an annual report. The last one that I've seen is the 2019 annual report, and they also have state data sheets that break down kind of each state and how, that state compares to the region. So how New York would compare to the Northeast region, and then how states kind of compare against each other as far as, veteran suicide rates and risk. Then on the next slide, I had just a screenshot of what the New York veteran suicide data sheet looks like. And so for privacy purposes, they don't break it down by county because you could have, 1 or, less than 10 suicides, and it may be easy to identify, individual people. But it does really break down some specifics, comparing the amount of New York suicides were veterans versus general population, and then the rates for the different age groups. And those are all available online, and I had put a link on the previous slide.
So now this may have changed in the last year because there has been some increase in gun homicides. But if you look at it in general, this is what is taking us to look at method a little bit more carefully. People talk a lot about homicide, but actually in New York State, there's been an increase in gun suicides and a decrease up until 2017 in gun homicides. So while that gets all the attention, homicides, actually the suicides by firearm are a larger problem. And we've learned some things about the method that people choose, the importance of restricting access to the most lethal ones. So
yeah, so when it comes to suicide, prevention, we really often focus on why people complete suicide, and the reasons for that are complex and layered and multifaceted, right? And we certainly want to be able to find some solutions to the why people complete suicide. So we want to make sure people have access to having basic needs met, having their housing met, access to mental health treatment, access to pain management, mental health treatment, et cetera, et cetera. We could probably talk about all the reasons that go into the why, probably all day. But we've also learned that it's really important to focus on how people attempt suicide. And when we talk about lethal means reduction, we're really referring to this practice of securing or locking, or securely storing lethal means such as firearms or medications to really provide some time and distance between a person in crisis where your brain just doesn't allow you to process things accurately when we're in crisis or we have really strong emotions. So we're wanting to while we also focus on the why of suicide, focus on these practices that are able to put time and distance between a person in crisis and means that could be used to attempt suicide. So I think even years ago, right, no one knew these phrases, friends don't let friends drive drunk, right? And now that's a very common phrase. You see it on billboards, it kind of rolls off the tongue. We know that you're not supposed to drive drunk, and that doesn't mean that everyone sort of follows that practice, but it was a very common public health messaging. And I think those of us who are in the suicide prevention world or have had loved ones die by suicide are really hoping that this practice of securing lethal means when a person's in crisis, or even kind of doing it as a routine practice, becomes as routine to us as that phrase, friends don't let friends drive drunk.
So I've learned about this with some studies that have been done recently. And the Israeli Defense Force had a rather high suicide rate. And most of those suicides were by firearm. Many of those occurring on weekends when the soldiers were on leave. And you can imagine that's when maybe the relationship issues would come up, or there might be substance use, drinking, etc. And the intervention that they decided on in 2006 was to require the soldiers to leave their weapons on base during weekend leaves. Now, there was some resistance to that, as there is typically with these interventions, saying, well, if you prevent them from taking their life on the weekend, they're just going to wait till Monday, or they'll find another way over the weekend. They'll find a different method, or they'll just wait till Monday. What interestingly happened is the overall suicide rate decreased by 40% with just that intervention. The weekend suicide rate dropped, but also the weekday one. So the time and distance from that method, that very lethal method, actually had a large impact. And this is the kind of research that leads us to think that this is an important opportunity to try to impact suicide rates. And if you look, All right. One of the issues that's illustrated here is that firearms are the most lethal method. You can see that up to 90% of the time with a firearm, the person will die by suicide as compared to other methods, which are most often not as lethal on a first attempt. We also know that if a person can survive their first suicide attempt, they have a good chance of not eventually dying by suicide. Most of those people, about 90%, do not eventually die by suicide. So the importance of avoiding a very lethal method is critical. Now, typically cutting and poisoning in particular, poisoning refers to an overdose, is typically not as lethal in the general population. But there is, I was just doing some recent reading about a new study that came out, and nurses have a much higher, twice as high rate of suicide as the general population. Nurses and some frontline medical workers, and they would have the knowledge about and the access to very lethal medications. But for the general population, firearms are the most lethal method. We would also, when you're working with clients, we don't want you to share with them the low fatality rate for sharps and overdoses. We don't want to encourage people to try more lethal methods, but we want people to know that 9 out of 10 firearm attempts are fatal. Let's take a look at this now. This brings us down to our own county, and this is last year's data. We're actually, you can see that 2/3 of the suicides are in the category of either a gunshot wound or a hanging. And we've not been able, we've been talking and trying to do some interventions on reducing access to firearms, and we have not had an impact on it. We did not in the last year. So it's something we're going to continue to work on. Hanging was actually just about the same number last year, and they typically kind of go up and down, but those are the two methods that are most used in the fatal suicide in Erie County. Now, the hanging one is a little harder to intervene on a public health method because there's so many ways that one may take their life by hanging. So we do, though, do some education, and during crises, people can limit access, monitor people, family member or friend who might be at risk and is talking about using that as a method. But the firearm has the opportunity for a very clear intervention.
And these are charts that show kind of methods as far as, the United States veterans. And so I think the statistics nationwide for general population are about 50% of men complete with firearm, and I think it's 25% of women. So those are increased when it comes to veterans. And, it may be due to familiarity with firearms, due to their career and training. They may be more likely to own firearms. And I guess I want to say, owning a firearm doesn't put you at higher risk of suicide, right? But it does put you at higher risk of a suicide completion if you were in crisis and to have an attempt. The lethality is that much higher. So I think there is a lot of room for some intervention around, safely storing firearms as a crisis intervention. I found this information really fascinating the first time I heard it. I worked in the mental health field too long to mention at this point in life, right? And, in the mental health field, sometimes you work with people who are more chronically suicidal, people that have had some thoughts of suicide for a lot of years, even up to a lot of decades. But there was some research to show, these people at the bottom, our cited source here, did a study on people who had attempted suicide. And they asked them how long they had been thinking about the specific plan and method they used before the attempt. And so 24% had been thinking about it for less than 5 minutes. 48% had been thinking about it for less than 20 minutes. and 71% for less, for within an hour. And so, some of this research on suicide and suicide attempts has really helped even to dispel some of my own myths that largely, suicides and suicide attempts, not always, but it's, this is showing 71% of the time, it's a pretty impulsive decision. And so if we can put some time and distance between someone that's not doing well, has some very legitimate, whys for suicide, is really maybe struggling in more than one area, has tried, probably even tried a lot of things to make some improvements. But if 71% of people are thinking about the specific method they use for less than an hour, 24% with less than 5 minutes, there's a lot of room to kind of drive down the suicide rate just by looking at really lethal means for suicide. Are you guys tracking with us? It's so weird to do a presentation and only see the host. It's very nice to see you, but do we have any questions at this point? Certainly we can answer any questions throughout and at the end as well.
No questions have come up yet in the chat.
Okay.
Is that a question? No, I thought someone was unmuting. Okay, following along. Okay, good.
Oh, before we move on, maybe one question just came in. The question is, what are the stats on the other 29%? I think
Ones
it might be
who have-
referencing the time.
Right, in the previous slide. I can't say that exactly offhand. I think it goes out hours and even days. It's pretty scattered, that other 29%. You're not going to get, there are people who are sort of chronically in a state of having thoughts of suicide that may, slightly decrease or increase, but they never really remediate completely. And that is a group. This, it's different. It's a different group. There is a large percentage that this lethal means approach can have an impact on. Yeah, it's a good point. I just can't tell you the exact number on that. I don't know if Katie knows. Do you?
No, I don't either. And it's a good question though, and it will be one that I write down and pull up for the next presentation, or can get information back to Amy and Kathleen too, if we can find it more specifically in that article. But I think the point for me was, there's a lot of times that we think or hear, comments from other people like, you really can't prevent these things. If people, make up their mind, you can't prevent it. And I think in some cases that's true, but it's very eye-opening to see the 71% there for less than an hour.
Mm-hmm. I think that a good point to you in terms of using this information, when you're doing safety planning, first of all, letting people know that often suicidal thoughts can pass within a reasonable amount of time can help them to be more engaged in a safety plan and to give them some hope. Because a lot of time the hopelessness that comes out of it is that around the fact that I'm always going to feel this way, it's never going to get better. And if a safety plan can work to give them some self-distraction, some coping skills, things to do that even aren't necessarily related to suicide, just to get through an hour or so. Some people, we just say, go to sleep and wake up in the morning and see how you feel. Then that can help get them past that suicidal crisis. And they do have hope then that it's not always going to be something that's going to last forever. And I see there's a question about whether the percentages correlate to poisoning. Yes, it's for any method.
Yeah, these percentages are for any suicide method. And I think that should be a takeaway point if all the people, so they're studying people who, survived a suicide attempt and had all those people used a very lethal means, within 5 minutes of a crisis or 20 minutes or within an hour, that would be a larger, suicide completion rate.
So in terms of this part, why do means matter? The emphasis is on the fact that a suicidal crisis can be brief, and it often is that way. And it's an important thing, as mental health recipients, as professionals, to know that some methods, particularly firearms, are far more lethal than others. And we know that the rate really is very high. There's very little opportunity for rescue and for survival with a firearm. And we also know that more than 90% of those, 9 out of 10, who attempt and survive do not go on to die by suicide. So it's critical to try to avoid a very fatal attempt. We also know that people who are suicidal are ambivalent often. Part of them wants to live, part of them wants to die. In one large study that was done of people who survived a suicide attempt, they actually said, I didn't really want to die, I just wanted the pain to end. So if we can help them to survive that attempt with time and distance and keeping them away from a highly lethal method, that can save a life. Okay. Stop, catch myself. So who should practice lethal means reduction? Well, we know that everybody can go through hard times. So even not every client that you have is currently suicidal, but taking precautions can save a life later. It can be sort of a form of inoculation. It's a good thing for everyone to do. And it can also protect loved ones and pets from accidental harm, such as ingesting medication or accidentally discharging a loaded firearm. So the things we're talking about are things that everyone could practice as a way to keep their homes safer. Family members, particularly of someone who has mental health struggles, or if a family is going through, say, a divorce, a relationship problem, a big financial crisis, those are the times that you want to be particularly aware. Family members can see the warning signs even before a clinician. Knowing the way to practice safety can empower them to take action to protect their loved ones who may be going through a hard time. And particularly if there's someone with dementia, the caregiver would want to be sure that there are no lethal means available because as the person's cognition declines, they can also attempt suicide, and you don't want a method, or it could be even accidental in those cases. First responders and the military, as Katie talks about, are a particular challenge because they have difficult work. They experience trauma, repeated trauma often, and they have access to a firearm.
Yeah, and then specifically veterans, kind of knowing these like best lethal means safety practices can help veterans not only protect themselves, but also like that peer-to-peer approach is really powerful, right? Just like Celia was saying, family members are often the first to see, any signs of that someone in their family is struggling or having a hard time. I think the same happens for, friends of veterans, right? So this can be important for you to practice for yourself if you're a veteran, and for the people in your lives. And firearms are our most lethal, suicide method. I just thought these, statistics were poignant, but 1 in 2 veterans owns a firearm. They've been highly trained in the use of firearms since it was part of the work that they did. And that 66% of veterans have at least one unlocked firearm in their home, and 1 in 3 veterans have a weapon unlocked and loaded at home. So that can really increase the risk of unintentional injuries. If you have kids or pets in the home, or just, wouldn't realize that a firearm in your home is loaded. But it also makes it really easily accessible to someone in crisis, whether it's yourself or someone else in your family. So we don't just want to focus on firearms. We want to focus on medication safety as well. So I think we all have 2 different types of medication around us in our home, right? So necessary medication, things that we need for a health condition, or that, really need to be, have close access to, and then unnecessary medication. So when it comes to necessary medication, if someone's, at risk for suicide, we could ask for medications to be dispensed in smaller amounts. So we might not send them 120 days worth of 10 different medications. It can also be dispensed in blister packaging, depending on your pharmacy. Some family members, or even, people that have struggled with, thoughts of suicide, or, concern about overdose, will put them in a pill separator too. So you'd only have a week's worth available to you. And there's also, like, our prosthetics department here at the VA will sometimes give them to higher risk veterans for suicide, but specific, like, medication dispenser machines that are timed to dispense medications, because sometimes the barrier when a patient is leaving our inpatient psychiatry unit is they're saying, yeah, this is really a concern for me. I'm struggling, but I don't want to die by suicide. I need some help with my medications, but there's no one available to do it every day or twice a day to dispense medications. So we've been able to get some of these safes where someone fills it up for a month, and it just, it unlocks, your morning meds at a certain time, your afternoon meds at a certain time, your evening meds at a certain time. And then there's certainly plenty of people I talk to, as far as patients at work, that just have, like, a lot of medications at their home that are expired or no longer prescribed to them, but they got a large supply. It's really just wisdom to, just get those out of your house. So I've listed here, at the VA, our pharmacy has envelopes that you can mail medications in to be disposed of. So we could mail you, 10 envelopes, about 3 pill bottles fit in each one. So we can mail you as many as you need, and you mail those in for proper disposal. And then there's also disposal sites in the community. So I'll see, even in the town that I live in, sometimes there's, like, a medication drop-off event where medications can be safely disposed of. And then I listed 2 websites here too that can be good resources on how to safely dispose of medication.
I've also talked about this at senior centers, because grandma's medicine cabinet can be, have years of medication stocked in there, and, and think about, maybe a grandchild or a grandchild's friend who comes over. You wouldn't want them to have access to that. You have to think about visitors to your home.
Of course. And I think we wanted to talk about alcohol safety too. So alcohol, especially in large amounts, and other drugs too, can, increase the risk of us making some impulsive and maybe, negative decisions that have some consequences later on. It can also be really dangerous when, even unintentionally mixed with medication that you're taking. So, really being wise as, like, providers, right, to talk with the patients that we're working with about their alcohol use, about getting them treatment if they're, excessively using alcohol, and really limiting as much as we can quantities of alcohol in the home until someone's feeling better. And then firearm safety. I mean, if you were to talk to any firearm instructor, right, they're teaching these practices as a part of, firearm ownership. Safety is, one of the top tenets of, the firearm community. So it's always a good practice to keep firearms locked and unloaded, to store your ammunition separately. It's especially important when there's children, pets, or people who are having some crisis in the home. And then particularly if you're intervening with someone who is having a hard time, to take a minute and really have some courage to kind of ask if they have access to firearms, and discuss how they might, plan to lock that up and give someone else a key, or to change the code on a safe, or even to store it outside the home for a period of time. So whether they can give it to a family member or friend, depending what type of firearm it is, or store it off site in a locked storage unit, or, local firearm retailers have, storage that you can pay for. Also, police departments can be a good option as well. And then certainly the VA offers free cable gun locks. And so, we give those out at different tabling events, and I'd be more than happy to, give them out to anyone who would want to use them personally or with a population that you serve.
We've included them in the bags that the crisis services mobile outreach team use. So if they're going to a home and there is a firearm there and people understand, yes, I need to get this locked, but you know, it's late at night, they can give them a free cable lock that has been provided by the VA.
Okay.
And people can at least temporarily use that to keep their firearms secure until they're able to make other arrangements. We'll talk to you about some resources for that too.
Yeah, I just wanted to say real quick too. I mean, often when I would speak in person to people about this, it's very easy to become, you know, firearm restriction, right? Or locking up firearms can easily feel like a political issue or kind of like a red button issue. And people have a lot of opinions and feelings about it, right? And so I often joke like, well, I'm a social worker. Like, I'm not going to come to your house and take your firearms, but your safety is really important to me. And actually think it's important to have that discussion around, you know, we all like to have, you know, as much control as is possible, you know, over our lives and our decisions and our circumstances. And so I'll actually talk with veterans about how, you know, getting treatment and safely storing firearms actually makes you less at risk to, you know, have to comply with the New York Safe Act and things like that. So practicing these lethal means reduction practices on the front end is, you know, a lot more beneficial as far as your choice, you know, to own a firearm than to have a crisis, you know, and have, you know, the police come to your house. You may be at risk of, you know, having to store that somewhere else involuntarily for a time.
I just make a note that someone mentioned in the chat, some Tops markets have drop off boxes for medication, and I think other pharmacies as well. And this slide is actually, I know you can't see the whole map, but that's okay. This is just a screenshot of, this is a resource that we've put together for you from the Erie County Suicide Prevention Coalition. So this is on our website. And what you can do is you can go to this and share this with clients, friends, family, because there's a few things about firearm storage that are a challenge. First of all, as Katie mentioned, we are not about taking away anyone's Second Amendment rights. That's not what we're talking about. And people have sort of a negative reaction, firearm owners often, to the SAFE Act. They don't want their firearm taken away from them. So this is something that you can do as a prevention, and you can do it voluntarily. We've made each of the dots represents either a local gun shop or a gun club or a law enforcement agency who is willing to accept voluntarily firearms for temporary storage. Now, you tell people they may have anything that's on a permit, you can't just give it to somebody else who's not listed on the permit. So technically, legally, you just can't give your pistol to your brother to hold on during a crisis, because if he's not on the permit. So this is legal and safe. You can take it to one of these locations and you can leave it there until you're through the crisis. Many of them do not require also a mental health evaluation to retrieve it. So that's another thing people are concerned about. You know, if I get my firearm taken away from me during a mental health crisis, I'm going to have to go and get a psychiatrist to say I'm okay, and who wants to do that? And it becomes a challenge. So what is, if you click on any of these little icons here, you can find out their location, what they charge for voluntary firearm storage, and any restrictions they have about how to pick up the firearm afterwards, how to get it back if you do have to get any kind of evaluation. Actually, all the independent gun shops and gun clubs don't seem to require that. They may rerun the background check, though. That may be something that they do before returning it. But and I found also that the New York State Police will even come to the home and pick it up, because that's another thing. You don't want the individual who's in crisis to be handling the firearm, a loaded firearm, and taking it somewhere. That's something to avoid. So you can use this resource from our website, and there's a little video actually that accompanies it that tells you how to use it exactly. So it's clear and it's a resource that we have for the community to use.
Did you mention the website address?
I don't think I did.
Okay. I was just thinking they're easy to find, but it's on like this the Suicide Prevention Coalition of Erie County website. It's right on the face page. If you scroll down, you'll see a link to the map and a link to this video.
I will put that in the chat before we sign off, so you'll all have it. Because if I say it just off the top of my head, I'll probably get it wrong. Okay. This is a brochure that we've developed, and this is something that to be used in a client counselor situation. This is not something we want to see just left out in waiting rooms for anyone to pick up or for a young person to pick up. It should be explained and described, and it's got a little picture of the house, and it gives people ideas. Just keeping your home suicide safer, and you even if you're talking to people, they may not be an immediate suicidal crisis, but these things, it's good news that they are sort of they come up quickly, but that's also harder to deal with. So someone can leave your office on Tuesday and not have any thoughts about suicide, and then something happens Wednesday or Thursday, and that's what they're thinking. So this is about prevention, about keeping your home safer. And it talks about each of the risks, what to do about it, and gives you some hints. And let me see if I go back a page. Resources, and it also has the risk factors, the warning signs, and hotline numbers. So it's a nice little packet. We will give you our email address, my email address, and I can get those to you in a electronic version. Actually, maybe Amy, we can link it to the recording of this. Maybe that would be a good way to let people have access to it. But I do encourage anyone to use it in a situation where it's discussed and given it to someone who understands the reason. You don't want to be out talking about methods and have that as general information.
We have
This
a couple questions that came in if you want to field them now. One is, what are appropriate resources when someone's behavior is escalating with threats to others? The escalating behavior may be dismissed as not a threat because the person doesn't own a gun, but since we don't know this person's breaking point, what can or should be done?
Talking about threats to others.
Mm-hmm.
Threats to others should always be taken seriously. I mean, it's not really the key topic of this presentation, but whether or not someone may say they don't have a firearm, but they may have access to it. So I think that is always something to be taken seriously, and to I always say take suicide threats, suicide comments seriously as well. Never discuss, never, if it needs to be evaluated, and that needs to be within agency policies reported.
Yeah, I was going to say too, because I'm not sure the audience that we're talking to, if we're talking to all like licensed mental health providers, but you'd certainly want to, as a mental health provider, make sure you're doing a complete assessment of the threats and take them very seriously, or get them to someone who can do that mental health assessment. I think we're kind of getting there in the point, the part of our presentation as far as crisis resources as well.
Mm-hmm. And someone asked about the brochure, which we will include with the recording, or you could email me separately if you want for it. Now, this is something that the Suicide Prevention Center can offer locally in person, and it's an online training program. Many people who work in the mental health field don't really have a lot of knowledge about firearms, may not know how to talk about them, are not seen as credible people in terms of sharing firearm knowledge. And I'd like to mention here too that we are getting together a video for firearm safety classes that talk about suicide and the importance of keeping your home suicide safe in terms of your firearms. And that is being edited and should be ready for distribution soon. And Dr. Kirsten Vincent, was interviewed for that because she and her husband were hunters, and particularly her husband. So they were interviewed talking about the importance of firearm safety in the home. And now that video will be done in her memory. The CALM training is Counseling on Access to Lethal Means. You can get the online version at the Suicide Prevention Resource Center. You do have to log in and create an account. And also, I am considered a master trainer and could do this program locally if there is a need for it with a particular agency. It's based on the evidence-based practice of counseling on access to lethal means. It talks to people about how to talk to clients about this very sensitive topic, when to talk about clients, gives you some video clips and opportunity to practice some of the skills. So it's a good program. If anyone would like that, please give a shout out. And lost the little thing to advance the slides. There's one little tiny thing to advance these slides, and it just seemed to disappear on me. This last one. Shut this off maybe.
Let me advance it somehow, so I just moved it forward. Okay.
Okay, can you move it?
Can you see the next slide or no?
No, maybe that's
Oh, maybe it's just showing me personally, sorry.
okay. Here's the little, let's see if I got a different way. Sorry, folks.
On the left-hand side, is there like a little up and down arrow above a number?
Yeah,
Does that move it?
that's just disappeared. Yeah. Let's see. Okay, what do we got there? Maybe I can do this without the slide. I showed you the brochure. Okay, well, we have some information on, basically, we're wrapping up with, here it is, it came back, yay, okay. I don't know where it went. Crisis services, all right, for anyone who needs assistance 24 hours, there's 24-hour mobile outreach, a mobile crisis response service for emergency mental health crisis for people 18 and over, trauma response program, and postvention support. People may not be aware of as well, if someone does experience a close family member or friend's suicide, they can do postvention support. They can come right out to the home after a suicide and provide that critical support after the death. And this is their number. You can also contact them if you're thinking about someone, you're not sure what you should do, you can contact them anonymously and ask for some advice. For 18 and for under 18, we have Spectrum Health Cares team, and their number is 882-4357. And they work with young people, same types of services, but for young people. This is for veterans, the free confidential support 24/7. And you use the National Suicide Prevention Lifeline number and press 1 for a veteran issue. And they've got some great resources that they'll link you into. They're really working very aggressively on this topic. Okay, so let's see, I think that's all we have. Let's see if there's any questions or comments that we've not responded to.
No new questions that came in yet.
I see Amy put the website link for the Erie County Suicide Prevention Coalition in the chat. So you should be able to access that, and you can see the map. I'm going to put our, go ahead, Amy, you want to talk about the evaluation?
Yeah.
In our contact information back up. The email address for Katie and for me are up on the screen. Okay, in the
Yeah,
chat.
we really appreciate, I was going to say, we just appreciate your time and attention and for letting us come talk with you. And, you know, if there was something that you wanted further training on, you know, please reach out to Celia and I. If you had anything veteran specific too, I'd be happy to kind of talk with you about whatever those needs are.
The evaluation link is in the chat. Please complete it. We find that helpful to get some feedback. And to register for the July session, there's another link which follows. Anything
Okay.
else?
Any other questions? Nope. Well, Katie and Celia, I can't thank you enough. This has been awesome, as always. So the link for the evaluation and the next session have been posted in the chat box. Hope to see you all again, and we really would like your feedback to make this better. The July session again is about co-occurring disorders by Jillian Warner Dombrowski. Would love to see you there. If you're interested in being a presenter, please let me know. If you have ideas for topics, please let me know that too. Email me, call me, however, that would be great. And again, thank you, Katie and Celia. Thank you, Kathleen. And thank you all for coming today. I hope you've enjoyed the presentation.
Amy, if I could also, I see a couple of people privately asking for further training. If you could send a note to me to my email address, cspacone@crisisservices.org, because I won't have your contact information after the WebEx closes. Tell me what your interests are, what you need, and I'll be happy to respond to that. Thanks.
And if
Yeah,
down the
thank
road you haven't written down Celia's contact information correctly, you can email me and I will get it to Celia. So I can help with that as well. Okay.
Thank you all.
Celia. Thank you, Katie. Thank you,
Thank you.
Kathleen. And thank you all for being here.
Thanks. Bye, everyone.
Thank you.
I know.